Hi, I'm Dr. Jacqueline Sheehan, and this talk will go through anorexia, cachexia, and weight loss in geriatric and palliative care, including a broad overview of how it relates to our patient population, as well as some strategies on how to approach and manage it. I have no relationships or disclosures with a commercial interest to report. So the goal of today's session is to discuss and distinguish between syndromes of anorexia, cachexia, sarcopenia, unintended weight loss, and malnutrition, identify non-pharmacologic as well as pharmacologic treatment options, and also to discuss the impact on quality of life, prognosis, and communication in patients living with serious illness. So first, defining what it is. Anorexia is a symptom we can often see in our patients that they will describe as a loss of appetite. Cachexia may be a consequence of this or a clinical manifestation with muscle wasting or loss of skeletal muscle. And this muscle wasting can occur in acute as well as chronic condition. So we can see anorexia, cachexia acutely in things like burns or sepsis, but most often in our patients, we see it chronically with progressive illness and disease. Cancer is what we most often think of and where it's best described and where the bulk of evidence focuses on, but most chronic conditions like heart failure, COPD, renal and liver failure, eventually with progression will all lead to cachexia. So putting it together, the combined symptom burden of anorexia with presenting cachexia is often referred to as anorexia-cachexia syndrome. Starting with a case to go into more specifics on this, here we have a 67-year-old man with metastatic colon cancer with liver mets. He's no longer a candidate for further cancer-directed treatment, and he's coming to outpatient palliative care clinic for follow-up. His family is especially concerned about his lack of appetite and weight loss. He doesn't feel like eating. He has overall increased weakness, abdominal discomfort, as well as discomfort when swallowing. He has recurrent malignant ascites and gets a paracentesis on average once a month. He's on low-dose oxycodone, 5 milligrams every 4 hours as needed, and his last bowel movement was 6 days ago. Physical exams remarkable for white patches along his oral mucosa. He also has a distended abdomen with ascites and a large amount of stool on exam. So given all this information, thinking of where to start and what would be an appropriate assessment and evaluation for his lack of appetite and weight loss. So taking this case and using it to anchor us as we look at a patient with anorexia and likely cachexia and taking a step back to do a whole person assessment, thinking through contributors or secondary causes that we can identify and treat to help reduce the effect on their appetite and overall weight. These can be symptoms related to the underlying illness and treatment itself, so chemotherapy or radiation causing mucositis. They can also be symptoms and syndromes that may contribute to reduced intake, like worsening pain, reducing the desire and ability to take orally. So thinking through any changes in smell or taste that can be caused by treatments that they might be on, it's important to think of the digestive system from beginning to end to identify possible culprits. So orally, looking to see, do they have a dry mouth? Do they have inflammation, ulcers, or an infection like thrush? Could this be the result of a digestive problem? Do they have nausea, vomiting, abdominal pain, constipation, or even obstruction? And also wanting to look psychosocially and see, is there any undiagnosed, untreated anxiety or depression, or in some elderly patients, delirium that has gone unrecognized that's causing their reduced intake or loss of interest in eating. And lastly here, not as common, but wanting to make sure we're thinking through everything, not wanting to miss any possible metabolic or endocrine disorders that could be driving a catabolic state. So things like hyperthyroidism, B12 deficiency, or adrenal insufficiency. With cachexia, there's really no single agreed upon definition for it. The key is certainly recognizing that it's weight loss and muscle loss. Some more recent studies and definitions have also tried to look at things like inflammatory markers, physical performance measures, as well as quality of life measures. That being said, a lot of studies utilize the international consensus definition, which looks at weight loss of greater than 5% in the past 6 months, or 2% if your BMI is less than 20 to begin with, to define and characterize cachexia. Here on this at the bottom, we see the different stages of pre-cachexia, cachexia, and refractory cachexia. And this occurs as part of a continuum as the serious illness is occurring and progressing. So in pre-cachexia, patients will have some weight loss, but not a full 5%, and some anorexia symptoms along with that. At the other end, refractory cachexia is often when we can typically see patients maybe referred to palliative care, or it's certainly applied to a lot of patients that we see. So from cachexia to refractory cachexia is often when we think about medications that can be used to help with appetite and with weight gain. As patients progress across this, they can have worse outcomes. So increased weakness, greater symptom burden overall, poor quality of life, and shorter survival. And because approach and treatment can vary depending on the stage, it's helpful to be able to identify and classify the stage your patient is at when you're seeing them. There's a lot of effort research looking into, different interventions, treatments that can delay the onset or development of cachexia or delay progression of cachexia to refractory cachexia. So next case, we have a 78-year-old woman with Parkinson's disease, early dementia, depression, hypertension, prediabetes, and osteoarthritis, who presents to outpatient geriatric clinic for a routine visit, accompanied by her daughter. She complains of poor appetite, and her daughter reports she's lost 12 pounds in the last year, and her daughter asks if she should be worried. So based on what we have so far, thinking, is this clinically significant weight loss? And does our patient meet criteria for malnutrition? And how can we screen for and measure that? So unintentional weight loss in adults older than 65 years is generally defined as 5% or greater loss of body weight in a 6 to 12 month period and is associated with increased morbidity and mortality. Unintentional weight loss in older adults can be classified as unexplained, unintentional weight loss when no definable cause is found, or as unintentional weight loss with a known origin. And we can see our patient, when we look at the numbers, she lost 12 pounds or 10% body weight in the past year and has a BMI of 18, meaning she has clinically significant unintended weight loss. Looking at the breakdown of specific causes of unintentional weight loss in geriatric patients, we see that organ-related illnesses and non-malignant GI diseases are the most common identified causes, followed by cancers, psychosocial issues, or unexplained weight loss. In organ-related conditions, congestive heart failure leading to fluid buildup can mask weight loss, but it will lead to a higher metabolic demand and decreased appetite. Similarly, in COPD, with an increased effort to breathe, raises metabolic demand, and symptoms like shortness of breath can lead to reduced intake of food. Cancer is a major cause of unintentional weight loss, especially in middle-aged adults, though non-malignant conditions are going to be more common overall in the elderly. And social and psychological factors can significantly impact an older adult's nutritional intake, with depression as a common cause of reduced appetite and weight loss, especially among long-term care residents. Isolation and the loss of social interaction can diminish the motivation to cook and to eat, and a factor that can worsen depression. Also, financial constraints can limit access to sufficient or nutritious food. Things like impairment in daily activities, lack of transport, or poor living situation create lots of barriers to obtaining and preparing meals. A significant proportion of cases, regardless, will remain unexplained even after thorough investigation. In other instances, it's as part of a broader syndrome of aging. So with frailty, we can see unintentional weight loss, low physical activity, and muscle weakness, which is often associated with age-related malnutrition and inflammation. So how we can screen for malnutrition. So first, here on the left, the short nutritional assessment questionnaire is a validated, quick, easy to use screening tool developed to identify individuals at risk of malnutrition in both hospital and outpatient settings, especially in geriatric patients. It consists of lots of questions related to appetite, food intake, and unintentional weight loss. And the answers are scored to produce a total score, which is going to categorize the patient as being low, moderate, or high risk for malnutrition. And patients identified as high risk should then be provided with a specific nutritional intervention or treatment plan. On the right, we have the mini nutritional assessment, another validated screening tool for identifying older adults who are malnourished or at risk of malnutrition. It involves simple questions, simple measurements, so things like BMI and weight loss, assessing dietary intake, their mobility, and their overall health. And a low score indicates risk of malnutrition and is going to warrant further evaluation and intervention. The Global Leadership Initiative on Malnutrition here provides a framework for diagnosing and also grading malnutrition. It uses 3 phenotypic criteria, so weight loss, low BMI, and reduced muscle mass, and 2 etiologic criteria, so reduced food intake or presence of inflammation. This approach is going to be preceded by a malnutrition risk screening, and then after screening, you're going to assess for these 5 core criteria. So you're going to try and identify the presence of at least one of the following on the left: weight loss, low BMI, reduced muscle mass, and then the presence of at least one from the other 2, so decreased food consumption, or maybe impaired nutritional absorption, or an ongoing disease burden or acute inflammatory condition. And malnutrition is diagnosed if there's a match for one from each criterion. And then the severity of the malnutrition is assessed based on that, as you can see here at the bottom. The Meals on Wheels acronym is a mnemonic, goes through all reversible causes of weight loss in older adults to think of and work through when seeing a patient with unintentional weight loss. So medications and the use of multiple medications is a common cause of poor appetite in older adults. Side effects like nausea, dry mouth, and altered taste can all reduce the desire to eat. Reduced mobility from weakness or illness can make it difficult to shop for food, prepare meals, and even eat. And the inability to maintain an upright position while eating can cause problems, especially when you think of stroke patients. Depression often presents as appetite loss in older adults, can be mistaken for dementia or other illnesses. It's going to lead to low nutritional intake, weight loss, and other nutritional deficiencies. Loneliness, especially following loss of family and friends, can lead to a decreased appetite and avoidance of meals. Things like memory loss, impaired judgment can lead a person with dementia to forget to eat, forget how to chew and swallow, and become distracted during mealtime. Difficulty or pain when swallowing is obviously going to hinder food and fluid intake, can be a major cause of malnutrition, dehydration, and aspiration pneumonia in older adults. Dental problems, so wanting to think of any ill-fitting dentures, are also going to cause pain and difficulty chewing, leading people to maybe start avoiding food or certain foods. Decreased saliva production with age can make it difficult to chew, to swallow, or even taste food in the same way. Thinking of endocrine conditions, so hyperthyroidism, hyperparathyroidism can lead to weight loss. Other causes include eating problems associated with weakness, stroke, tremors, and enteric issues with conditions like celiac and malabsorption syndrome. And also need to be mindful of any restrictive diets a patient might already be on, so maybe a heart-healthy diet, and also overall reviewing, their access to food and possible food insecurity that many may not volunteer initially as being a reason or cause. So some medications can interfere with nutrient absorption or metabolism, and others can cause nutritional side effects by altering appetite, taste, or digestion. So first, medications that decrease appetite can lead to unintentional weight loss and nutritional deficiency. So common ones are ones to be aware of, certainly. In geriatric patients, things like cholinesterase inhibitors, SSRIs, PPIs, and H2 blockers. A dry mouth can decrease enjoyment of food, make eating difficult. Thinking of medications like antihistamines, antidepressants, antipsychotics, benzodiazepines, and especially diuretics. Some medications can also disrupt the sense of taste, maybe some causing a metallic or a bitter taste, and also wanting to be mindful of the constipating effect of medication that are going to slow gastric motility and also decrease appetite and intake as a result. So ones to really be mindful of here, things like opioids, also iron supplements and antihistamines. An important distinction is the difference between sarcopenia and cachexia. So sarcopenia is age-related loss of muscle mass that is then going to lead to loss of function and loss of strength in our geriatric patients. So this is compared to cachexia, which is illness-related loss of skeletal muscle and loss of body weight. The key difference is in cachexia, you get increased inflammation, which does not happen in sarcopenia, and you also get an increase in the basal metabolic rate, which you also do not get with sarcopenia. So mealtime routines for older adults can be improved following specific guidelines on setting, preferences, preparation, taste, assistance, and time. So a comfortable, supportive environment to help enhance appetite, make meals a more enjoyable experience. With the setting, using comfortable, supportive chairs, tables of an appropriate height to promote proper posture, and when possible, having the person eat with family, with friends, as a shared meal can increase appetite and provide social and emotional benefits. Asking what foods they would like, including, favorite comfort foods, culturally significant dishes, recognizing that familiar foods can trigger positive memories, maybe increase their interest in eating overall. Food should be modified with the texture to accommodate any chewing or any swallowing difficulties they may have. So this may involve soft, minced, or pureed meals. And also food should be served at a safe, pleasant temperature, keeping in mind that for some older adults, they may have reduced temperature sensitivity. Things like using herbs and spices, maybe instead of salt, as the sense of taste for salt and sweetness can decline with age. And some may require feeding assistance, maybe use of adaptive utensils and equipment as needed. And you also want to allow plenty of time for the person to eat without feeling hurried, especially as eating in some instances can take longer for older adults. So while protein calorie supplements help weight gain and energy intake for undernourished older adults, the evidence is mixed regarding their effects on other outcomes. So supplements are most effective for those with existing malnutrition or sarcopenia, especially when it's combined with things like resistance exercise. Supplements consistently produce a small but reliable increase in weight and overall energy intake, but the evidence is inconclusive for mortality benefit in the older population. Some studies have found that a decreased risk of mortality for those who were already undernourished at the beginning of supplementation. The evidence of supplements improving physical functions, things like gait speed or the ability to perform daily activities, is overall weak. There are some positive effects, especially when it's combined with things like exercise, but really no clear benefit. And there is no consistent evidence that supplementation is going to reduce things like the overall length of a hospital stay. And it's important to remember that these supplements should be given between meals rather than as a meal replacement. And this is to prevent supplements from decreasing the appetite and overall intake of regular food or regular meals. So our next scenario is a 54-year-old man with pancreatic cancer undergoing chemotherapy treatment who comes to clinic with complaints of loss of appetite despite improved control of his previous nausea and vomiting when he started treatment initially. He's gone to lose 35 pounds since his diagnosis. On exam, you see that he is cachectic with some temporal wasting. So which of these agents is likely to be most effective improving his appetite and weight? So mirtazapine, olanzapine, megestrol acetate, dexamethasone, or dronabinol. And in this case, olanzapine is going to be the most effective for both his appetite and weight. And next, we'll be going through why that is based on the evidence we have. So the recommendation for olanzapine is a more recent recommendation following a randomized control trial that looked at patients with locally advanced or metastatic gastric and lung cancers undergoing chemotherapy and experiencing anorexia and cachexia. So starting with chemotherapy initiation, patients received olanzapine at a dose of 2.5 milligrams once a day, or they got a placebo. And they found that patients who received olanzapine over this time course had improved appetite and weight gain of more than 5% compared with those taking placebo. It was overall pretty well tolerated, no real toxicity, but it can cause increased drowsiness when starting. And you also need to keep an eye on their EKG given its known effect with QTc prolongation. So it may be reasonable to apply this and use in other patients with other cancer types. Corticosteroids have been shown to have benefit in treating anorexia, especially in patients with advanced disease. It helps stimulate appetite, improving food intake, and has energizing effects. Dexamethasone is often selected given its prolonged half-life, lots of ways of giving it, and relatively low mineralocorticoid effect, so less likelihood of fluid retention when we compare it to other steroids like prednisone. A dose of dexamethasone 4 milligrams a day has been shown to be effective. It's generally only effective for those symptoms in a pretty narrow time frame, anywhere from 2 to 6 weeks. Corticosteroids, as we know, are associated with a number of side effects, thinking of hyperglycemia, fluid retention, and longer-term complications like myopathy and peptic ulcers. So for these reasons, it's most helpful to use in patients for a short period, or especially thinking of patients with a short prognosis, maybe somewhere in the order of weeks to months. Although a medication that has definitely fallen out of favor, Megace, a progesterone analog, has been shown to be beneficial in the treatment of anorexia and cachexia in patients with cancer and HIV/AIDS. Improved appetite can be seen within a week or so starting treatment, and weight gain can take a couple of weeks, but the weight gained is primarily fat and fluid and not muscle gain. The usual effective dose ranges from 160 milligrams to 800 milligrams a day. So for this reason, it could be reasonable to start with a dose of 400 milligrams a day, maybe reassess in 2 weeks. And if there's no change in appetite or weight, increasing to 600 or 800 milligrams a day and reassess again in 2 weeks. If there's no clear benefit at this point, then I would consider stopping it completely. Why it may be reasonable to stop if it's not effective at 600 or even 400 milligram dose range is because the studies didn't show any additional benefit beyond the 800 milligram a day range, and those studies were done with the tablet formulation. So if you're going to be prescribing the oral liquid, which has a better oral bioavailability at a dose of maybe 400 or 600, and it's not effective, this is likely close to the equivalent of 800 milligrams in the tablet dosing. Its side effects are really important to be aware of, especially as higher doses may lead to increased risk. So most important side effects to be aware of are venous thromboembolism, so DVT, and adrenal suppression or insufficiency. Given its effect on gain of water weight, can also cause edema. Particularly geriatric patients are more likely to experience side effects or harm than actual benefit from this medication, and it's listed on the Beers lists for older adults. So putting it all together, this is the ASCO guideline rapid recommendation update from 2023. Key takeaways from this update is to recommend that clinicians offer low-dose olanzapine once daily to treat cancer-related anorexia cachexia in adults with advanced cancer. And for patients who cannot tolerate low-dose olanzapine, clinicians may offer a short-term trial of Megace or a corticosteroid to those experiencing weight loss and loss of appetite. A medication we think of in our patients who may have a symptom presentation with depression, insomnia, and anorexia is mirtazapine. So dosing for mirtazapine ranges from 7.5 to 45 milligrams a day. It's going to work as a serotonergic and noradrenergic antidepressant, and also as a histamine antagonist, which is why it's beneficial for insomnia, with lower doses of 7.5 to 15 milligrams, more helpful for symptoms of insomnia with less antihistamine effect at higher doses. We know that patients who have depression and are treated with mirtazapine are going to have improved appetite and weight gain. That being said, there's really mixed evidence in the absence of depression. There was some promise for improved appetite and weight gain in non-depressed cancer patients at doses from 15 to 30 milligrams a day. But more recent trials showed that mirtazapine was really no better than placebo in improving appetite in cancer-related anorexia and cachexia. I think the key takeaway would be to think of using it in patients with depression and other associated symptoms. But in patients without depression, it's really not clear that it's helpful in treating and addressing anorexia and cachexia alone. So going through some other agents that can come up. So dronabinol is one that we see prescribed not infrequently. It is FDA approved for HIV/AIDS-related anorexia and as a second-line treatment option for refractory chemotherapy-induced nausea and vomiting. These studies in the 90s looking at anorexia related to HIV showed that dronabinol did improve appetite, decrease nausea, but actually didn't lead to significant weight gain. And no benefit has been shown when it's been used in cancer-related anorexia and cachexia, despite its activity and benefit in patients with HIV. And especially in older adults, it has a lot of side effects like sedation, confusion, visual disturbances, and tachycardia that make it less appealing to use. NSAIDs have been an area of interest given the pro-inflammatory effects from tumors or chronic conditions that can drive some of this. They have found that NSAIDs can improve some body weight in cancer patients, but really no benefit or effect seen with appetite. And overall, the evidence is really too weak to recommend clinically. Omega-3 fatty acids showed some benefit in patients with pancreatic cancer who had improved weight and improved body mass, but overall not compelling evidence to support a net benefit in cachexia in cancer patients. There's also work looking at novel agents, novel monoclonals that may show some promise in cancer-related anorexia, cachexia, but nothing that is currently or commercially available right now. So coming back to one of our patients from earlier, a 78-year-old woman with Parkinson's disease, dementia, depression, hypertension, and osteoarthritis, who continues to decline with advancing dementia. She's become more frail, is fully dependent for ADLs, nonverbal, and bedbound. She's also developed worsening dysphagia and is currently hospitalized for aspiration pneumonia for the third time this year. Her daughter calls you to discuss her care, as she's very distressed about her eating and nutrition and asks you if she should have a peg tube for feeding. So this graph, I think, really effectively illustrates the timeline over the course of dementia from mild to moderate to severe and end stage. And in end stage, we can see patients are largely in bed and nonverbal, like our patient currently. In terms of function at this stage, they have progressive problems eating and recurrent aspirations or other infections as a result. So the AGS advises against feeding tubes in advanced dementia. So research shows that tube feeding is not only ineffective, but can also cause significant harm in patients with advanced dementia. The risks include increased agitation and need for restraints, as the feeding tube can cause patient discomfort, maybe leading to them pulling it out. And this often results in the use of physical or chemical restraints, which can reduce their quality of life significantly. The immobility and the restraints associated with this may worsen any existing pressure injuries or can increase the risk of developing new ones. In addition to PEG site infections, patients with feeding tubes are at a higher risk of aspiration pneumonia. So the tubes don't prevent the aspiration of saliva or gastric contents, which can still lead to infection. You can also have tube-related complications like dislodgement or blockage, and these can cause distressing and unnecessary hospital visits. And tube feeding removes the social and sensory experience of meal times, which is maybe a significant source of comfort for many with dementia. Tube-fed patients have high mortality rate that is not improved compared to those who are hand-fed, and it doesn't lead to reversal of the functional decline that is part of advanced dementia. In contrast to the burdens of tube feeding, hand feeding offers a gentle, compassionate approach that really focuses on quality of life. And the decision to eat less or stop eating is a natural part of advanced dementia, and hand feeding can continue as long as it's comfortable for the patient. In patients with cancer, enteral nutrition, such as a feeding tube, is beneficial for those undergoing treatment for things like head and neck cancers, or if they have a GI malignancy that's causing obstruction. However, in end-stage cancer, the benefits are not proven, and placement of feeding tubes may carry a higher risk of complications and not improve quality of life. For patients with ALS, evidence suggests that PEG feeding, especially when placed before significant respiratory decline, can extend survival in ALS. So in these patients, it helps maintain body weight and muscle mass, which may support strength and function for longer. For patients who've had an acute stroke, enteral nutrition is necessary to ensure adequate intake, and a PEG tube can be placed for nutritional support and access for medications. An artificial nutritional support doesn't have proven benefit in end-stage organ dysfunction, so things like end-stage COPD, ESRD, and end-stage cardiac disease. And in advanced cancer patients who have poor performance status, the expenses, the complications, and burdens of parenteral nutrition, so things like TPN, often outweigh the benefits, and guidelines recommend against its use in these patients. So parenteral nutrition has a high risk of complication, including increased infection rate in patients with advanced cancer, as well as the central venous catheters required for this, creating a direct portal for bacteria for infections. For advanced cancer patients with poor prognosis, the potential benefits of parenteral nutrition are often marginal and are frequently going to be outweighed by the burdens. Lots of studies have concluded that for advanced, non-curable cancer, parenteral nutrition doesn't offer survival advantage, and some have even found that it's associated with lower survival rates. Next, artificial fluids near the end of life often cause more harm than benefit, especially for patients with a short prognosis. As the body naturally declines, its ability to process fluids diminishes, and forcing hydration can lead to significant discomfort and other complications. So this excess fluid can build up in the body's tissues and lungs, causing edema, causing dyspnea. And the use of IV or sub-Q lines carries a risk of infection, especially in frail patients. The lines themselves can also cause pain, swelling, and restrict a patient's movement. And while dehydration can sometimes contribute to delirium, the side effects of hydration, so things like electrolyte imbalances and fluid shifts, can also cause or worsen confusion and agitation. And important to note that fluids don't improve quality of life, so don't help symptoms like thirst, fatigue, confusion, or nausea in patients with poor performance status or prognosis of less than a month. So, the goal of feeding a person nearing the end of life is not to provide sustenance, but to offer comfort, pleasure, and even human connection. So, families should feed slowly, gently, ensuring person is upright and has swallowed each bite. And this is going to minimize the risk of choking and aspiration. They should stop feeding immediately if the person coughs, chokes, or shows any discomfort. And also, forcing a person to eat can cause distress and add to their overall discomfort. And as a person eats and drinks less, their mouth can become dry. And so, keeping the mouth and lips moist is a vital comfort measure. So, families can offer ice chips or sips of water to keep the mouth wet. They can use a soft toothbrush dipped in plain water to gently moisten the inside of the mouth and the tongue. And they can also use water-based lubricant to help keep the lips moist and prevent cracking. For many families, providing food and drink is an expression of love and care. So when a loved one stops eating, they may feel helpless. So educating them on what to expect can alleviate some distress and provide alternative ways to show their care and affection. And lastly, it's important in the initial stage to explain to patients and families what is going on. The changes they are seeing with the loss of appetite, changes in appearance can be distressing. Family members may have thoughts and concerns about why they won't eat, maybe why they don't want to get better, or they may view it as a failure to provide care for their loved one. And it can be complicated even further by their background and cultural beliefs, recognizing things like feeding and sharing food as ways they provide care and show love. We talk about the loss of appetite, the weight loss, and changes in their body as part of their condition, and reframing it all as part of the illness or the disease that is not in their control. It can be helpful to encourage the social benefits of being at the kitchen table with other family members, emphasizing the pleasure of tasting food over chasing calorie intake. It can also be really challenging talking about eating and feeding near the end of life. We talk with patients and families at this stage that increased calorie intake will unfortunately not reverse the underlying process, and that loss of appetite and weight loss are common and expected in people at the stage of their condition. It can be helpful to look at words we're using when talking about all of this, especially for the topic of artificial nutrition as nutrition by a tube or through the vein versus calling it or referencing it as eating. Given how loaded this topic can be surrounding eating, drinking, artificial nutrition, and hydration during the dying process, it's important to spend some time eliciting their values and worries and validating and attending to their emotions and addressing the differences between starvation and hunger versus expected changes as part of the natural process that occurs at the end of life. And thank you all for listening to this talk.